Okay, let's dive right into this explainer. Today, we're looking at how we can fundamentally shift our vestibular clinical practice. Far too often, we just rely on subjective impressions to gauge how a patient is doing. They come in, they say they feel a bit better, but what does that actually mean for their dynamic fall risk or their daily function? We're going to learn how to replace that guesswork entirely with data-driven, defensible outcomes that truly prove the value of your rehab programs.
This explainer is based on outcome measures in vestibular rehabilitation, published by Australian Dizziness Clinics. You can find this entire document, along with a bunch of great clinical resources, available at australiandizzinessclinics.com.
As clinicians, we really have to ask ourselves this critical question: what actually separates a defensible, rock-solid 6-week vestibular rehabilitation result from a flimsy subjective discharge letter? Well, the answer is a retested baseline evaluated against a minimal clinically important difference. Because as the source material makes incredibly clear, numbers travel, but impressions do not. When you're communicating with a referring neurologist or an ENT, a vague sense that a patient is doing better just doesn't cut it. They need the data.
Think about it. An invisible, subjective impression is basically just a guess. Actually, scratch that. It's not even a guess. It's a massive blind spot that stands in stark contrast to a defensible, retested baseline that is grounded in meaningful data. Without numbers, 6 weeks of physiotherapy is literally just an impression, and it simply does not travel outside your clinic walls. But with data, you have a concrete, traceable trajectory of recovery. You establish a clear starting line, measure the functional gap, and document the exact path taken to bridge it.
Here's our roadmap for today's session. First, why we measure outcomes. Second, the ICF framework. Third, meaningful change and the MCID. And finally, tool selection based on presentation.
Let's start with Section 1, Why Measure Outcomes.
Measurement isn't just about collecting numbers for the sake of filling out a chart. It actually performs 4 specific, absolutely crucial jobs in your practice. First, it documents the baseline severity, so you know exactly how severe the functional deficit truly is on day 1. Second, it tracks progress over a typical 6 to 12-week rehab program. Third, it immediately identifies clinical plateaus. If you hit a wall at week 8, your data acts as an early warning system indicating you need triage or a change in strategy. And fourth, it produces the hard evidence that referrers and funders demand to authorize ongoing care.
And here is a pro tip. Plot that change visually for the patient. Buy-in lives in the chart. Vestibular rehabilitation is hard work, and let's be honest, it can often provoke symptoms before improving them. Seeing that upward recovery curve is incredibly motivating for your patients, especially during those inevitable plateau weeks where they might feel like they're stuck. Showing them the graph proves they are actually holding on to their physical gains.
Moving right along to Section 2, the ICF framework.
This shows us exactly how we organize our thinking using a globally recognized foundation. Different treatment tracks, whether that's vestibular rehabilitation therapy, cognitive behavioral therapy, or pharmacological interventions, map directly to the International Classification of Functioning Domains. We are looking at a complete framework covering body function, activity, participation, and quality of life. Ultimately, all these interventions funnel down into meaningful functional recovery over a 12 to 24-week timeline. If you're only treating the inner ear and ignoring the broader participation limitations, you're missing the whole picture. To build a balanced clinical battery, you've got to hit every level. Map body function via gaze stability and balance tests, map activity via dynamic gait scales, and map participation via patient-reported measures of confidence and handicap. By selecting exactly one validated tool per domain, you stop redundant testing. You don't need to do 3 different walking tests while completely ignoring a confidence measure. This structure saves time and guarantees you're covering both the subjective and objective perspectives every single time.
Okay, Section 3, Meaningful Change and the MCID.
This is a vital paradigm shift. We have to talk about thresholds, not just p-values. The minimal clinically important difference, or MCID, is the smallest patient-meaningful change threshold. Let me be clear on this. Reporting a statistically significant p-value without MCID context actively misleads people. A 2-point drop on a symptom inventory might be statistically significant if your sample size is huge, but in the real world, it's just clinical noise. We need to track changes that cross the threshold of the patient actually feeling a tangible difference in their daily life. So these are the exact headline MCIDs you absolutely need to memorize. The Dizziness Handicap Inventory, or DHI, needs an 18-point swing. The Activity Specific Balance Confidence Scale, or ABC, requires a 10% change. The Functional Gait Assessment and Mini-Balance Evaluation Systems test both require a 4-point shift, and the Visual Vertigo Analog Scale needs a 9-point change. If a patient improves by, say, 10 points on the DHI, your physical exam might look a bit cleaner, but based on the MCID, they haven't truly felt the functional difference yet. You have to hit these specific targets.
And finally, Section 4, Tool Selection by Presentation. Strict sequencing for your subjective reporting and objective performance testing is totally non-negotiable. You can't just grab whatever questionnaire is on top of your desk. These decision trees show exactly how to branch your tool selection by clinical presentation. This ensures your selection always matches the clinical mechanism of the dizziness, prioritizing targeted relevance over sheer convenience. Someone with acute vertigo needs a fundamentally different testing battery than someone struggling with visually induced dizziness in a crowded grocery store.
Let's apply these rules to some different patterns. For an acute peripheral loss, your battery should be the Dizziness Handicap Inventory, the Functional Gait Assessment, and the Modified Clinical Test of Sensory Interaction on Balance. For persistent postural perceptual dizziness, or visual dependency, you'd use the DHI, the Visual Vertigo Analog Scale, and the ABC scale. And for functional dizziness, you lead with the ABC, the DHI, and a brief mood screen. Always match the battery to the underlying clinical pattern.
And crucially, you've got to time this battery properly. Take your baseline at session 1, then retest every 4 to 6 weeks. Retesting more frequently than every 4 weeks is honestly just wasteful, and it can frustrate patients if they don't see massive leaps every single session. But retesting less than every 6 weeks, that means you might completely miss crucial progression triggers. Finally, you discharge your patient based on reaching normative cutoffs across those domains.
Let's quickly wrap up with our key takeaways. Remember to measure to do the 4 jobs, ensure your battery covers the ICF domains, always rely on that patient-meaningful MCID threshold, not just p-values, ensure your selection logically follows the clinical pattern, and above all else, plot the change visually to secure patient buy-in. Before we go, I want to leave you with a thought. Which patient-reported tools hold the key to uncovering the exact emotional and functional handicaps driving your patient's dizziness? How might diving into those specific tools fundamentally alter your treatment focus?
In Part 2 of this explainer, we walk through patient-reported tools, the Dizziness Handicap Inventory, Activity-Specific Balance Confidence Scale, Visual Vertigo Analog Scale, and Neck Pain Questionnaire. For additional resources, visit AustralianDizzinessClinics.com. Subscribe and rate to support the series.